The sign-in is complete, the patient is prepped, the local anesthesia is ready, and your primary healthcare team is standing by. To get this patient safely through the procedure and out the door without a preventable error, we have to execute the final 2 phases of the surgical checklist. The WHO-adapted surgical safety checklist provides the specific sequence of checks required for these final stages. Nailing these final steps takes a routine minor procedure, which often lacks the safety net of a full hospital operating room, and anchors it in rigorous, structured control. Step 1 is the timeout. This happens immediately before the first incision or before administering any regional or local anesthesia. Think of this as a hard stop. Every team member in the room ceases movement. The surgeon physically puts down their instruments. Total focus shifts strictly to the checklist. You start by having everyone introduce themselves by name and role. In a primary care setting with rotating staff, this step ensures every single person feels empowered to speak up if they see a problem. Next, the team verbally reconfirms the patient's identity, the exact procedure being performed, and the specific surgical site. Then, you verify the sterility of the instruments and the integrity of your sterile field. Finally, check that all necessary sutures, tools, and emergency medications like epinephrine or an airway kit are physically present and ready for use. You cannot afford to leave the room once you begin. The timeout creates a final pause where the procedure cannot proceed until every team member has verified the same set of facts. Fast forward to the end of the procedure. Before the patient even leaves the procedure area, you initiate the sign-out phase. This begins with a high-stakes reconciliation, the instrument, swab, and sharps count. The surgeon and the circulating nurse use a call and response method. Both must audibly confirm that the number of needles, blades, and swabs matches the exact count you started with. Warning tone. Do not let anyone start cleaning up or disposing of trash until this final count is verified. A lost needle in a biohazard bin derails the entire verification process. Missing a sharp in a primary care setting is a severe liability. Data shows that 1 in 3 adverse events in outpatient surgery connects directly to inadequate procedural assessments and checklist lapses. A verified count is the only reliable way to guarantee the patient leaves your facility without a retained object or internal complication. With the sharps accounted for, you move to the final administrative checks before transferring the patient to recovery. If you collected a biopsy or any other specimen, label it immediately while the patient is still in the room. Read the label aloud to ensure absolute accuracy. Next, document any equipment malfunctions or complications that occurred during the procedure. Capturing this now prevents recurring hardware failures later. Finally, provide the patient or their caregiver with clear, written post-operative instructions. Then, arrange for the mandatory 30 to 60-minute post-op observation plan. Following these GAHAR standards ensures a seamless, monitored transition from the procedure table to a safe recovery at home. Completing the sign-in, timeout, and sign-out provides the full layer of procedural verification required by GAHAR standards. The numbers back this up. Consistent application of this checklist drives a 40% reduction in surgical site infections and drastically lowers undetected adverse events. Now let's put this into practice. We are going to run a live team-based simulation using a standard lipoma removal case scenario, because ultimately, surgical safety doesn't come from an individual's technical skill. It comes from an entire team's disciplined, routine adherence to a structured framework.